Hi, everyone. This is Cheryl Parker. I am the current president of the American Nursing Informatics Association, and I am honored today to be talking with Julie Luengas, the CNIO at Stony Brook in New York. And I know it's been a rough couple of months, Julie. I so appreciate you coming on and talking with us and, kind of sharing the story of what's happened up there. Could you start out by telling us a little bit about Stony Brook?
Sure. We are a relatively young organization. We're 40 years old, which is very young for a healthcare institution these days. We are located 50 miles east of New York City on the north shore of Long Island. And what's interesting about Stony Brook is when they built the hospital, they built it on the campus where the 7 health sciences are located, because they really wanted to ensure that we integrated practice with theory and bringing that evidence-based processes to our day-to-day operations. And all the schools are together: the medical school, nursing school, social work, OTPT, pharmacy, which is really a unique, to me, a unique design.
Cool. So can you tell us a little bit about this whole start? I mean, how has 2020 gone? I mean, we all started out wonderfully and then it fell apart. So could you tell us a little bit about your journey?
Sure. So here at Stony Brook, we were already planning for this before we started to see patients. Our incident command center met in early February and started talking about the what ifs and preparing of what it would look like, who would need to be involved, making sure that we had all the right people engaged. So when we did start seeing patients from the command center, we were prepared for that. But that wasn't our plan. We had a lot of projects that we were implementing. We had just kicked off our CIN that was supposed to be front and center in January, and so our clinical integrated network. And so we're still working on that, but it's not as at the forefront as we had hoped, but still trying to bring that together. We had implemented telehealth. It was not at the level that we had wanted, but of course with coronavirus, that has led to a huge uptake and telehealth implementation across our clinical practices.
What kind of challenges and barriers did you face in implementing that telehealth? Because I know everybody I've talked to had to do it like yesterday, really fast.
So one of our barriers on the island is we have a lot of areas that don't have great connectivity, which is surprising when you think of how close we are to the city, but there are a lot of areas. So it's one, helping the patients get access to get online, and it's also it's a behavioral change. So I'm used to seeing you in person, and now I'm going to be looking at you with the camera. So helping getting the cameras out to all of our clinical practices, finding out what our patients need, ensuring, if they don't have internet access at their home, where could they go to get access to it? With that, with our scheduler group, it was retraining the scheduler group to set up our telehealth appointments. So we had to build new appointment invites for telehealth. We created new notes for telehealth, which are a little bit different than the regular progress notes, and providing that support to our providers and our nurses and patients who are working on those visits. But it was definitely a need as you start to shut down all your clinics and you don't have appointments available and the patients need to be seen. We had to rapidly employ a process that we could still provide care to our patient population.
So you actually built new documentation screens for telehealth?
We did.
How'd you roll out the training on those?
So our training was virtual training. So with my team, they developed job aids. They also created videos for our patients to show them how to get online. We use Microsoft Teams. So they showed them how to download Teams for the telehealth visits. We had virtual training with providers and with schedulers so that they could ask questions at the end, but we used the platform Microsoft Teams to do our virtual training. And our team, I want to say they had about 10 sessions that they held.
That's good to know. I use Teams in one environment, but not in another. So it's interesting. I actually like it a lot. it scares a lot of people sometimes, but
Well, in virtual training, we had not done that before. So like a
ah.
instructor-led class to using virtual training. So that was a big shift for us too.
And how did your population, how did both the patient population and the provider population handle that switch?
So it was a little slow in the beginning, and when I say the beginning, about the first 7 to 10 days, but
Mhm.
once providers started using it and our patients using the solution, we had an increase in appointments being scheduled, and they're seeing how it is useful. So it is a big change, and dermatology is finding how great it is that they can look at different things with the cameras and get the best views. So they're really starting to embrace it. And as we look at our plan, because we still have in-person visits, we're just trying to do the social distancing with that sense, but we don't see it going away. It's going to stay with us as we go back to day-to-day operations
Yeah,
eventually.
I'm hearing that it's there's certain things we've had to implement that have been so well embraced that it's like, no, it's not. It's kind of like online education. There was a period when I can remember back that far ago where it was like, oh no, 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 all online education is just, crummy and terrible, and it's all a scam. And now it's totally mainstream, and pretty much every major university has an online component
Mhm.
at least. So yeah, I agree with you. I don't think telehealth is going anywhere.
No.
Um, so what kind of things did you have to do, not only in the inpatient environment? So let me ask another question first. Do you guys own anything beyond like primary care and hospitals? And do you have any long-term care facilities, anything like that?
So we don't own a long-term care facility. We do have a relationship with the Veterans Administration, which is sort of across the street from us. And we have 2 community hospitals that are out on the North and South Fork. We have one in the Hamptons and one on the North Fork out on Long Island. I'm in a lot of practices.
Okay. So what else beside telehealth, did anything else have to change? Did you change your inpatient documentation? Did you have to do any remote um, stand-up tent sites, anything like that at Stony Brook?
Yes, absolutely. So the first things, well, they were going simultaneously. So we were looking at the ED and how do we separate this potential population with COVID from the rest of the population. So what our organization did with our ambulatory surgery center, as elective procedures were being discontinued at the moment, we had our patients with respiratory symptoms heading over to our ambulatory surgical center, which meant we needed to change the build from an IT perspective to provide additional ED beds in that location, which then includes all the clinical decision support that's needed to care for those patients. So that was the IT build from it. Then eventually, as we prepared for the surge at the same time, taking clinical areas and changing them to med surge or ICU bed locations, which building extra locations, beds, also billing based on different procedures and things that are typically done in one area, clinical decision support. As our patient volume increased and ED visits, then we ended up opening a tent over on the university side of the campus where patients went for ED visits over there, which was also next to the tent that the DOH and the state had set up for COVID testing. So they were in a tent over there, which meant, again, not only IT build for beds and locations, but also our technical teams had to get network out there, equipment, computers, everything you can to have an ED over there. So we had that going on. As the surge came up and we had closing more of the ambulatory areas on the main campus and turning them into beds, looking at ICUs. And then with an increasing, that volume increasing and the workload, at the same time, nursing leadership was saying, what do we really need to document to make sure that we're providing the appropriate clinical care for our patients and capturing what absolutely needs to be captured? And it's not that other information isn't important, but at this point in time, what's the most important things that we capture? So they did implement an emergency policy regarding documentation, making sure that we're getting those important items. You know, we need to have our vitals, what's going on with the respiratory status, those critical things, INOs for the patient. But some of the other documentation elements that helps us take care of our patients, but is not the most critical, that part could be put to the side. So we looked at, for example, we have clinical decision support roles that will suggest plans of care for the patient based on different documentation needs. We turned off all of those rules. They're still available if a nurse needs to document them, but trying to think of how can we reduce extra alerts and noise for that nurse so they can really focus on the important items. In addition, one of the projects we had planned for this year, we were going to look at our admission history, streamline it, go back, question every question on it to say, does it add value? Does it meet a regulatory requirement? How does it help take care of the patient? And if it doesn't, we were going to remove it. And this can take at least a good week just to go through those questions and get an agreement from all the different impacted groups, compliance, regulatory, legal, nursing. But we were able to get it done in 4 days involving all the right people, not in the same room or on a call at the same time, but going and visiting those groups and making recommendations. And our team was able to implement that build within 3 days, which is amazing. So, you know, everyone was working, you know, basically 7 days a week. You know, we had, you know, alternating teams, but getting that built in because we knew by implementing that we were reducing burden for those bedside clinicians, and all of us were dedicated of how we could help our patients and the clinicians who are taking care of them. Meanwhile, on the physician side, they were doing many of the same things in addition to pulling out new order sets based on the evidence. Like probably many other sites, we had many clinicians that were being redeployed to help take care of patients. So building these evidence-based order sets, the documentation tools for nursing and providers help guide those folks who might not normally be on the inpatient setting and who's helping our primary inpatient care providers.
A lot of work in a really short period of time, but it's amazing what we can do when we have to.
Yes.
Yeah, when you got to do it, suddenly you can get rid of a lot of the noise, even in those kinds of discussions that would normally take weeks and weeks. So a question for you. You've been through the surge. You're on the downside of it now. Hopefully we won't have another one in the fall, but we could. And there's a lot of evidence that suggests that we might well. What kind of lessons have you taken out of this experience that you can use for that next round?
So one of the lessons is we are not going to delete all these extra locations and beds that have been built. We are going to keep them hidden, but we're going to keep them. Lessons around also of, in our newer part of the building, which we call our Pavilion and Mart that opened last November, and our tower that's being upgraded, we found that in the new building there is integration between the equipment and the EHR and the dome lights and with alarming. But then as we brought in additional equipment to meet the needs of our patients and ventilators and things, we had equipment that was coming in that wasn't integrated with our systems. So that made us have to be aware of how do we make sure that the nurses can hear the equipment outside the room? How can they see the patients outside the room? Because if you're trying to be mindful of how much PPE you're using and you want to provide the right care for the patients, you also have to be conservative with that critical equipment. How can we make sure that as we bring in new equipment, we can still hear that equipment outside of a room? So those are some of the lessons learned that, you know, we've not had to bring in outside equipment like we did for this particular clinical event. And that's a big lesson learned, thinking about that and what's going to be the impact when you're rolling out new sites and using them in a different way than what was the original plan.
Yeah.
Another thing is research. So being a university and academic center, of course, we have all our protocols that we follow, but that turnaround time that we can get the data that they need in a timely fashion to make decisions. And that was a critical part of when we were looking at staffing and resources and what was going on with the treatments being provided.
Interesting. Yeah, I hadn't really thought about equipment that you couldn't hear outside the room. I mean, I did think about how hard it must be for nurses because, we tend to go back to that little nursing instructor that sits on our shoulder and talks into our ear and says, this is what you've got to do, and how hard it must be to reuse PPE when you were taught never, ever, 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 ever to do some of the things that we've had to do. You violated a whole lot of rules that you were taught were rules you could not do. So I guess for me it was a little lucky that I came from a world where I came from the days before there were paper masks and paper gowns. We were all cloth masks and paper gowns, and we reused it and we re-sterilized it, and that was how I came up in practice a lot of years ago. So we're having to even bring back some of the stuff that was done many, many years ago. So do you have, Julie, any plans for the future? What are the things that you're now thinking about based on what you've been through? Is there any plans there?
So we're going to continue with looking at our documentation and seeing what adds value, where are the redundancies, and thinking about that in the future, because particularly if we have a second wave coming, how can we make sure that the data that we're collecting is helping the patient and it's not noise? And it's very easy when you've had an EHR and you've been implemented for a while that we all get noise in it. So that's one of the things, looking at that and making sure that what we're turning on is adding value, is going to help the patient. With that also is looking at those things, because one of the things was what can we turn off? So one is keeping a list of where these things that are nice to have, they help the patient, but it may not be critical to direct patient care. It may be on a different level, that we can have that list available so we can meet back with our clinical leadership team to review. Here's the things that are currently alerting. Here's the things that are scheduled to occur, and make sure that do these need to go in the event that we have this second wave, and if it comes as it did this first time, and that way we can quickly identify things and turn them off much more responsive time than what we did initially.
Are you looking at it at all from a interprofessional viewpoint in, well, if so-and-so just did something, is it really required? If respiratory did something, is it required that nursing repeat it and do the same documentation within a 5-minute period? Are you looking at it from an interprofessional realm as well?
It's interesting you bring that up, because that's some of the conversations that we've talked about. When you think about it, it's the patient's record. It's not the nurse's chart, the physician's chart, the respiratory chart. And we've had high-level conversations around that, but I can't say that we have a definitive plan to look at it like that. But that would be very interesting if we could move to that route where we just have one chart and it's not our separate records. Although, we take a lot of data and we'll take it from nursing and put it into a provider note that can be pulled into it. But to me, that's not truly having one patient record.
When we first started doing EHRs and EHR design many long years back, nurses would say to me, but I'm losing the patient story. And I'm like, but who reads what you wrote? Does the person coming on shift after you read it? Well, does the physician read it? Does the respiratory therapist, who you've spent all this time, and of course we were still in the paper world then, but it was like, who reads it? of what value is it for you to write it? Is it only a legal record at that point? You know, back to the, if you didn't write it down, you didn't do it. So yes, I think this is going to bring some interesting questions for the future. Let me ask you one more question here before we wrap up, and that's all about the mental health side of our practice, all of us as healthcare professionals, and even not just healthcare professionals, our janitors, our dietary people, people who are so involved in this day-to-day disaster, let's just call it what it is. What are y'all doing from that perspective for everybody?
So what Stony Brook has done, and I'm really impressed by it, one of the things they started with is there's a meeting twice a day that any staff member can join that's run by our wellness champions, and they have different things to help you with a virtual person instructor and techniques that you can do to help reduce stress. In addition, throughout the day, they're putting different links out available for everyone. Some are breathing exercises, music. They have partnered with some of the different places locally that are offering, for example, virtual yoga classes. So they are constantly communicating with us, either tools that are available to us on site that we can use for de-stress, or we can call them if we wanted a one-on-one invite, in addition to letting us know what's available in the community. Another thing that they've done here is they've created a couple rooms that you can come in and just relax. And they have one that's specific for nurses, that nurses can come in. They have snacks, they have drinks, they have essential oils in there like lavender to help kind of bring calmness. They have a shower in there as well if you want to take a shower and just kind of really just let the day go for that. And I'm really impressed with what they've done and the frequency that they're communicating, providing information. And this is, I think if I'm correct, the 6th week, maybe it's the 8th week that they've been doing these twice a day meetings in addition to the other support they provide. It's really recognized. And then when you come into our building, there are notes from the communities, whether it's chalk, sidewalk chalk messages, posters up from patients. In the coffee shop within the hospital, there are messages all over there from patients and families and community members saying how much they appreciate what they're doing. And then there's constant, there's the community is just coming in there saying, hey, let us feed you. Let us, here's a cup of coffee. You have no idea who's bringing it in. It's pretty amazing. And that does a lot. With our team, and many teams have done this as well. So many of my team members are working virtually. I'm on campus, and so is the CMIO, and there are other people from IT who have to be physically here. But we have a daily call with the leadership team, and within my team, their leaders reach out to them every day, but twice a week as a team, we have a call together just to touch base. For the most part, it may not be work related, but it's, hi, how are you? What's going on? Do you need anything? There are some things that are work related, but it's just that visual touch base with each other. And we make each other turn on the camera so we can really see, how are you doing?
Yeah, we've gone from, I hate video calls, I'm not doing video calls, I got to get all made up, to now it's like, this is the new way of doing business in a lot of cases. And we've kind of not, it's kind of like, okay. In fact, one of my bosses asked and said, I wonder if we're just going to go back to wearing makeup when we start coming back on campus, because I'm teaching full time now. It's like, oh, I don't know, I don't wear makeup that much anymore. So, well, Julie, I really, really thank you for your time. Is there anything in conclusion you'd like to share with us at all?
I think the importance is us sharing information with each other and letting us know what we're doing, what approaches are we taking. And it can be difficult when you're really busy, but those lessons learned from other sites and hearing what they're doing can be a really big help. And I think there's an opportunity after we get through all of this that all of us can come together and talk about what we did, what worked, what didn't work. We can learn from each other and continue that knowledge sharing.
Yeah, because I honestly believe this will not be the last time. So we're a global world now. No one is isolated anymore. So
No, and when you look at it, you could see how it was just tracking towards us.
mm-hmm. Well, thank you again so much for taking time out of your busy day. I have been humbled by all of the nursing informatics leaders who have been willing to take an hour out of their day and share their experiences with everyone by doing these interviews. Basically nobody's said no. And a lot of people have contacted me and said, could we do this? Yes, we saw what you did. Can we share our story? Which I think is just phenomenal. So again, my thanks, Julie. Y'all stay safe up there. And we'll see you the next time we see you, which is the best we can do nowadays.
Thank you. It's such a pleasure to speak with you.
Absolutely a joy. Thank you, Julie.